Good afternoon, everyone, and thank you for joining us at Jonas Nursing and Veterans Healthcare for our 2020 webinar series. And we are the signature program of Jonas Philanthropies, which was founded by Donald and Barbara Jonas. Our program works in partnership with schools of nursing across the country to identify and invest in high potential doctoral nursing scholars. Today, we are going to have our presentation entitled Health Disparities Among African American Women. We have our speakers with us, Dr. Kelly Bryant, who is the Executive Director of Simulation and an Assistant Professor at Columbia School of Nursing's newly accredited Helen Fuel Health Trust Simulation Center. We also have Dr. Brittany Richards, who is the Clinical Instructor and an Assistant Professor at New York City College of Technology, and Dr. Camilla Barnes, the founder and owner of Barnes Health Affiliates. Just to remind you, we are the first and only privately funded program in the nation with a presence in all 50 states. And we're focused on the commitment to the nursing profession and veterans healthcare with over 1,200 scholars to date. I'd also like to acknowledge our Executive Director, who is also here with us today, Dr. Wanda Montalvo, the Executive Director of Jonas Nursing and Veterans Healthcare. And would you like to have something to say to our audience?
I just want to welcome everyone and remind folks that I will be following and tweeting. So please get involved and help promote a lot of the information that will be shared by our experts today. And thank you for joining us.
Thank you. So as a reminder, as she said, please be sure to follow us on social media. We're on Facebook and LinkedIn at Jonas Philanthropies and Twitter at Jonas Impact, and on our website at www.jonasphilanthropies.org. We will offer continuing nursing education credits for this session, so more information will be available at the end of the presentation. You can also see our media library of recordings available on our website, along with our list of upcoming events. And just as a final reminder, please remember to mute your microphone and use your chat function to submit questions. And we have our Jonas staff that will monitor and help moderate your questions throughout the session, and we'll present them at the end. Thank you, Dr. Bryant, Dr. Richards, and Dr. Barnes. We'll turn it over to you.
All right. Thank you for that warm introduction. So we're going to begin our webinar, and again, the title of our presentation is Health Disparities Among African American Women. And I'm here with three of my colleagues from the Greater New York City Black Nurses Association who will be assisting with this presentation. So I just want to review what we're going to cover today. So at the end of this webinar, we're going to discuss the most common healthcare disparities faced by African American women in the U.S. There are a lot of health disparities, so we're going to focus on mental health, breast cancer, maternal health, and cardiovascular disease and diabetes. You're going to be able to identify factors that contribute to healthcare inequities affecting African American women. And then we're going to summarize initiatives that can help reduce these disparities in the healthcare system. And we won't go into a lot of details. We had a wonderful introduction, but here are our three presenters for today. And I just wanted to start with just a quick case study. Some of you may know about these two cases. This first one, Shalone Irving. This was a 36-year-old African-American woman who was an epidemiologist at CDC. She was pregnant, had a known clotting disorder, and when she went to have her baby, had an uneventful C-section. However, afterwards developed some complications. She continued to go back to her OBGYN with complaints of swelling, headaches, elevated blood pressure, rapid weight gain, and she was constantly told that all these symptoms were normal after visiting several times over several weeks. Unfortunately, at her last visit, she was given a blood pressure medication, and she died shortly after her visit. Here we have an African-American woman, great educational background, had resources to go to a great facility, and still face this outcome. And then I think we all know who this woman is, Serena Williams, another example. In September of 2017, she had an emergency C-section of her daughter. And after her C-section, having had a history of pulmonary emboli, had stated, "I don't feel right," had shortness of breath, and said that she thinks she needs to have heparin and get checked to see if she has any blood clots. Again, Her symptoms were ignored. She was told that it was a side effect of her pain medication. And then further requesting, they did go ahead and do a CAT scan and found that she had, in fact, had pulmonary emboli in her lungs. So this I just use as an example of some of the health inequities, disparities that are faced by Black women. So we can't begin this conversation without talking about social determinants of health and health equity versus equality. So first, with the social determinants of health, these are the conditions in which people are born, live, learn, work, play, worship, and these affect health functioning and our quality of life. That has to do with childhood experiences, places where we live, our housing, pollution, educational levels, social support, how much money people make, employment or lack of employment. What are our communities like? What is the setting? Are we available to certain programs and resources? What's the nutrition, the food like in our neighborhoods? All of these play a factor and impact our health and well-being. And then I want to mention early on the difference between health equity, you're going to hear us talk about pretty frequently, and equality. So the difference is health equity and health equality does not mean, they're not the same thing. Equality means that we give everybody the same thing. And a lot of times that doesn't put us all at the same playing field. Although everybody has the same resources, we know in a population, different people need different resources. Some may need more than others. So instead of focus on giving everybody the same, we need to focus on equity. And that's the principle underlying the commitment to reduce, ultimately eliminate disparities in health and its determinants. And that way we can get people the benefits that they need that fits each individual. So what are some of those barriers to healthcare? One of the biggest barriers is that a lot of people have inadequate or they do not have health insurance. Particularly people of vulnerable populations, including the elderly, people of color, are some of the populations that have the most difficulties with obtaining effective health care. Patients that have Medicaid, they have experienced access issues, especially in certain areas where they live, where they can't find providers who will take Medicaid due to its reduced reimbursement rates. Also, another barrier is the cost of out-of-pocket medical costs. Everybody has a copay. Not everybody can afford all of the copay, especially when they have multiple doctor visits. And then lastly, medical debt. Even if insurance covers part of the medical expenses, some people can't even pay that 10, 20% that they're responsible for if they have a major illness like cancer or diabetes. And then we have to look at environmental factors that contribute to health disparities. We have to talk about where people live, and particularly with food. We don't think about that often, but that does play a major impact in health. 2.1 million households, they don't own a vehicle, they don't live near a grocery store. Some of the neighborhoods, lower socioeconomic neighborhoods, don't have access to healthy food. In these neighborhoods, we have a 2.5 times greater chance of finding a fast food restaurant versus a grocery store that serves healthy food. And also, there's a such thing as in these neighborhoods, and we can look at Flint, Michigan as one example, pollution. We're talking about either the water, the air. People that live in these neighborhoods have higher risk of these environmental factors, which can again adversely affect people's health. And then when we look at those environmental factors, what it leads to is people having more hospitalizations. For example, if you live in a neighborhood where you don't have access to healthy food and you depend on, you know, the McDonald's or the fast food restaurants near your facility for your dinner and your lunch, that can contribute to cardiovascular disease, diabetes, so that increases the risk of hospitalization in some of these neighborhoods. So you can see how it's all tied together. Another major impact is the lack of transportation, especially again in vulnerable populations that do not have access to a car, that have to depend on public transportation. Studies have shown that when there's a lack of transportation, that affects health because people cannot get to their doctor's appointments, or they may choose which doctor's or nurse practitioner, I should say, medical appointments to go to. They may skip or delay in picking up their medications due to transportation issues, or they may postpone receiving care because they cannot get to the facility. And then there's transportation barriers. There's also residential segregation. A lot of places, again, they don't have access to primary care facilities or they're too far. So that leads to people a lot of times seeking healthcare later on in disease process. So they may not be able to be seen until they have advanced stage breast cancer. So all these affect health. So why do we still have these health inequities? We know they exist. We've known they existed for a while. What are some of those obstacles to overcoming these? And a lot of it is just the inadequate long-term commitment to really implement successful strategies. African Americans, for example, were not in the place, fiscal or political positions to kind of advocate and make these changes in policy. Tackling disparities is not a priority for our politicians and our decision makers. And also, we know there's been studies that show that a lot of our healthcare providers, there is stereotyping and there's implicit bias that plays a role on the healthcare of people of color. And then structural racism. And this is defined as a system where public policies, institutional practices, and cultural representation, they really work to reinforce and perpetuate racial inequities. There's a lot of underinvestment in programs that are helping, that we need to help counteract these health disparities and these inequities. And a lot of times, some of the programs that are in place, such as temporary assistance for needy families or nutritional assistance programs, when budget cuts come around, they're the first programs that are cut, which leads to detrimental effects, again, to the vulnerable populations that need these programs and these services. I'm now going to pass it on to Dr. Camilla Barnes.
Thank you, Dr. Bryan. I will speak about health disparities when it comes to cardiovascular health and diabetes. So cardiovascular disease has been the leading cause of death in the United States since the 1900s, with the exception of 1918 when they had the pandemic flu. The annual cost of CVD care is approximately $351.2 billion, which has been increasing since 2003. It is estimated that myocardial infarction happens every 40 seconds. And stroke is the third leading cause of death. There are significant disparities in morbidity and mortality when it comes to CVD in comparison for Blacks to non-Hispanic whites. And complications associated with CVD include heart attack, stroke, limb amputation, end-stage renal disease, vision loss, and heart failure, and also dealing with the morbidity. So dealing with daily symptoms such as exercise intolerance, sleep disturbances, and disability. And then when you look at the rate of potential life loss, years of potential life loss prior to the age of 75, looking just at stroke, African Americans are triple the rates of in comparison to whites. So health disparities leads to earlier deaths, premature death, decreased quality of life, and loss of economic opportunities. And many of the risk factors are modifiable, such as smoking, obesity, dyslipidemia, diabetes mellitus, chronic kidney disease, and hypertension. And diabetes, as you already know, is an epidemic in the US with 30 million Americans who have diabetes, primarily type 2 diabetes. It's a largely preventable condition. And African Americans suffer from diabetes more than in comparison to whites. And we're also starting to see more and more cases of type 2 diabetes in adolescent population. So approximately 40% of Americans have diabetes or prediabetes, and the prevalence rate is expected to double by 2050, okay? So when we look at the causes of diabetes, genetics plays a major role. With type 2 diabetes, strong family history can increase someone's risk factor. However, if you look at epidemiological studies, you'll see that you can trace back to the first case of diabetes in certain communities. Physiology looks at, focuses on waist circumference and body fat percentage instead of BMI. So this is more predictive of insulin resistance and leading to type 2 diabetes, and also abdominal obesity. Behaviors such as lifestyle choices, sedentary life, lack of physical activities, and food choices, especially with cultural implications, can put someone at risk. However, there are communities that face food famines, food scarcity, and rely highly on processed foods, high carb, high sugar, and fast foods as a source of nutrition. And then healthcare access, as Dr. Bryan already mentioned, is focusing on areas on shortage of providers, so underserved areas, And there have been programs such as Health Corps to increase providers in these short areas of shortages. So the trend for access tends to be urgent or emergent, when many of these issues can be handled in primary care. We also have the majority of uninsured to be people of color. And as already mentioned as well, transportation barriers. So what is the state of Black women's health? So to no surprise, Black women are at highest rate when it comes to diabetes, hypertension, and obesity. We also looked at Black women in research studies. However, keep in mind that there's still a mistrust of participation in research trials, given the historical mistreatment of human subjects in research. For example, GYN procedures were done without anesthesia. Female inmates received hysterectomies without consent. So due to mistrust, there's a large underrepresentation of Black women in research trials. So there are current initiatives to increase diversity of human subjects in research. The National Institutes of Health has the All of Us initiative, which is aimed to diversify human subjects in research, and hopefully lead to precision medicine. So precision medicine moves away from the thought process of one size fits all approach to care. So meaning I give the same medication to all my patients and it should work. So this will hopefully lead to individualized care plan goals based on the population that the provider is serving. And also the outcome of reducing health disparities. So when you look at heart disease mortality from a historical context, you can clearly see that there has been many advances and improvement in treatment modalities and outcomes, and when it comes to heart disease over the years. So this chart is looking at 1960 to 1999. There's also been significant improvement in hypertension control. However, as you can see, the disparity has increased over the years. So looking at recent data, again, significant improvement, still disparities have not changed much. We also need to keep in mind that up until 1977, redlining was legal. So what is redlining? Redlining led to discrimination in housing. Also, if a highly educated, middle-class Black person wanted to seek out loans to get a mortgage or to start a business, they were denied loans despite having good credit and good income. So in comparison to low-income whites, they were able to get loans, access to loans, and also to have, home ownership and business ownership. So redlining still to this day, Black communities have not recovered from, and has had a detrimental impact overall on our health. This chart looks at risk factors for cardiovascular disease, and we look at high blood pressure, high cholesterol, cigarette smoking, and overweight and obesity in comparison from non-Hispanic Black women to non-Hispanic white women. And as you can see on this chart, these are only a few of the risk factors, but Black women are not necessarily at higher risk when it comes to all of the risk factors. So therefore, what does that say? The disparities lies in the treatment. And looking at diabetes, we see that, again, Black women experience higher diagnosis of diabetes and death rates. And when you look at hospital admissions for lower extremity amputations, the ratio is 2.3. And end-stage renal disease, the incidence rate, so that's the rate of newly diagnosed cases, is at a ratio of 3.5. So what does it say? This says that currently, many of our interventions and our funding goes towards tertiary care. So that's treatment at the end of disease management. So for screenings such as preventive screenings, such as foot examination, retinal eye examination, and 2 or more A1C measurements per calendar year, Black women have a lower percentage of these screenings, which doesn't make sense because if there are worse outcomes, they should have higher screenings. So we need to shift our funding, and also as providers shift our focus on primary and secondary levels of prevention, as opposed to lower extremity amputations or dialysis. When it comes to utilization of care, so there's a large disparity amongst ethnic groups in utilization of care and access to treatment. So that's screenings, diagnostics, life-saving procedures. So as already mentioned, lack of access to specialists is an issue, especially in poor and rural communities. On a personal note, recently I've referred a couple of my patients, one to endo for newly diagnosed diabetes case, and also to cardiology. And as a result, their appointment is 2 months out. Okay, so if you don't have insurance or you're underinsured, you have to wait probably a couple months or so to receive care from a specialist. In the meantime, where are they going? They're going to emergency room when these issues can be managed in the primary care setting. And some don't even make it to the specialist appointment. They end up passing away. There's also fears of providers to refer for diagnostic procedures or revascularization. So Blacks are less likely to have treatment modalities and also revascularization procedures. There's also lack of education and information. So language barriers. One of my patients went to the emergency room, Spanish speaking, and received a handout in English and thought that he had influenza instead of pneumonia. Okay, so giving information in patient's primary language is important. Also health literacy. It takes a lot to educate patients about their diagnosis, and the reality of things, you only have about 15 minutes or so in the office. And if you're only seeing someone, you know, once or twice a year, maybe even more frequently, you still don't have enough time to really go over the management of their healthcare goals. So we need a multidisciplinary approach to increase health literacy. There's also implicit bias. So there's implicit bias trainings for providers to understand their subconscious attitudes towards patients. So that could be ignoring pain, or assuming that everyone from a particular ethnic group always complains of pain. So when you miss out on certain cues or vital signs, the patient ends up having an adverse outcome or passing away. So implicit bias trainings are very important. And then lastly, with the lack of caregivers and savings to cope with loss of earnings, as already mentioned, you know, economic burden of managing chronic comorbidities, some people are not able to do so. So this is why we need to elect politicians who support the Affordable Care Act and also health equity, because the Affordable Care Act intentions are to address these barriers to utilization of care.
Okay, now we're going to switch gears and talk about women's health, in particular breast cancer and prenatal care. So when we look at African-American women and breast cancer, we are aware that African-American women have, when they're diagnosed, they tend to have a more aggressive type of breast cancer. The survival rate of African-American women is less than among white women, 78 versus 98% survival rate, so it's a significant difference. And also, there's a higher rate of Black women being diagnosed with breast cancer at a much later stage, and the cancer has already spread. It's another graph to show the incidence of breast cancer is almost about the same when we look at white women versus Black women. However, when you look at the death rate, you can see amongst white women it's 20.8, and among Black women the death rate is 29.5. So although we get breast cancer at the same rate, Black women tend to have a higher mortality from breast cancer. So we need to look at what's the reason for that? What's the cause? Is it genetics? Are there other environmental factors that we need to look at? Other recommendations too is making sure that we get people in for screening, particularly Black women, at an earlier, on a regular routine. And some of the ways that Healthy People 2020 recommended is making sure that healthcare providers, that we have these flags in the charting system so that when we know when our clients and our patients are due for these important screenings, not just breast cancer, it could be colonoscopies, the pap smears, so that we can call these patients in to make sure they get that preventative screening that's needed. And then when patients have an abnormal finding, make sure that we have a recall system so that we can check to make sure we have proper follow-up with our patients. Another program that has been helpful to try to decrease these health disparities when it comes to breast cancer is the National Breast and Cervical Cancer Early Detection Program. So what that does is it makes sure that women that are low income or uninsured or underserved have access to cervical cancer screenings, which is mostly pap smear and HPV, and also mammography. So getting them the screening that they need at either no cost or reduced cost. And looking at Black maternal health, there is a significant disparity when it comes to Black women versus white women when it comes related to pregnancy-related complications, and it's as much as 3 times higher among Black women. And the sad part about it is that 60% of these maternal deaths are preventable. They don't have to happen, particularly when it comes to cardiovascular conditions, which is 68% preventable, and hemorrhage, which is 70%. And these are the major causes of death when it comes to pregnant women. And another graphic representation, again, pictures speak volumes. You can see here that Black women have a significantly higher chance of dying due to pregnancy-related disorders. And there is a difference between the causes of death when it comes to pregnancy-related issues. Black women have a higher rate of dying from hemorrhage, from cardiovascular infection, and preeclampsia. And the main fact to know about all these conditions, that most of these conditions, again, are preventable. And when we look at maternal deaths, we can't just think about the women who are dying during delivery. We lose women a week to a year after delivery, a third during pregnancy, and then 36% during delivery and up to 1 week afterwards. So there is a huge time frame that we need to really be screening and checking postpartum women to make sure that they're still not at risk of dying from a pregnancy-related illness that's not just right after delivery. And the American College of Obstetricians and Gynecologists, which is ACOG, a very reputable organization, they have done research and they have acknowledged that racial bias within the healthcare system does contribute to the disproportionate number of pregnancy-related deaths among minority women. So what are those factors that are affecting maternal mortality? It's inadequate access to both reproductive services, meaning we need to make sure that women who do not want to become pregnant have the resources, have the birth control available to avoid unintended pregnancy, but also women have access to antenatal health care so that they're getting the care that they need during their pregnancy. Stress plays a major factor. We know that stress contributes to preeclampsia, eclampsia, has detrimental effects to the newborn, to the fetus and the mother. Poverty, low education, unemployment, environmental exposures, and low access to healthy foods have all been shown to play a role in maternal mortality and morbidity. And then let's go back to prenatal care. We need to make sure that African-American women are getting prenatal care early on during their pregnancies. In 2008, there was a study done that showed that only 59% of African-American women had prenatal care versus 72% of white women. So we want to increase the rate of women that are receiving regular prenatal care. And also, we found that 11.5% of African-American women receive prenatal care in the 3rd trimester. We want to make sure that all patients who are pregnant are seen in that 1st trimester. Because we know that when women have access to maternity care, they have positive health impacts, not only for her, but it's also for her child. And then we have to talk about the psychological effects of health inequities on the pregnant woman. We know that long-term psychological effects of racism, they do take a toll. And again, that adds to the stress of a woman during pregnancy, which we know can contribute, like I discussed earlier, preeclampsia, eclampsia, blood clots, and maternal mental health conditions. And then the women, we're talking about the pregnant women, but we also have to be aware that these pregnant women are carrying a baby, that those children are also at risk for preterm labor And with preterm labor, we know that there's a lot of detrimental effects with developmental delays, cerebral palsy. So when we're talking about the mother, we can't help but also talk about that baby, that neonate. And as you can see here, when you have a high preterm birth rate, you have a higher rate of neonatal death. And we can see that Black Americans have a much higher rate of neonatal death at 13.4 than any other race. So what can we do about it? How do we reduce this maternal health inequities that we've briefly discussed? Some of the recommendations are we need to fund and expand access to policies and programs that support families' basic needs. That's basic needs for housing, for food, for employment. Invest in community programs and services where it's one-stop shopping. So a mother can go and they can get their WIC, they can be seen as a patient, their children can be seen. So that is one visit that they can accomplish quite a few visits so that we can reduce transportation costs, make their visit more efficient. We have to make it easier also for women to navigate the healthcare system. It can be very complicated to enroll in programs such as WIC or getting Medicaid, Medicare. So we need to have people that can assist women with getting the insurance and the services that they need. Home visits, that's another great way that we can go, providing home visits to the mother, to the baby, such as the nurse-family partnership, where we can provide patient education, also screening, making sure that the baby is doing well and the mother. Eliminate maternity care deserts. Women should have easy access and close proximity to healthcare facilities, effective healthcare facilities, and not have to travel long distances to receive care. And we also have to strengthen the existing health programs that we have, such as Medicaid and the Children's Health Insurance Program. Because again, a lot of times when there's funding cuts, these are the programs that get funded and they adversely affect the vulnerable populations such as women of color. We also need to improve the quality of care provided to pregnant women. We already talked about the care that Black women receive and other people of color could be subpar to the care that others receive. So we want to make sure that we are educating our healthcare providers so that they know how to care for a diverse population of patients. And we need to make sure that the population that's caring for these patients is also diverse. Create standardized assessments for mothers and infants. We need to do a better job at screening and treating women for preterm birth. And we need to identify the barriers that why are people not going to get their prenatal care in their first trimester? What are those barriers? And let's find ways to eliminate those barriers. And also screening. We need to have early screening for both the mom and the child so we can identify a lot of these disorders, physical, medical conditions early on so they can get the treatment that they need. Some initiatives that are currently in place that are trying to help improve maternal health outcomes. Again, like I mentioned, ACOG, they're developing new guidelines so that we know that cardiovascular disease is a major cause of maternal death. So what are some guidelines that we can have for women, particularly women of color, so that we can combat women dying from cardiomyopathy after delivery? We need to extend postpartum care also. There are certain programs where just having a 6-week visit is not enough. A lot of time women may have complications where they need to be seen multiple times. And we want to make sure that we extend Medicaid so that it doesn't get cut off after 60 days. There's programs where it's extended because we know complications can happen up to a year after a woman gives birth. And then the Preventing Maternal Death Act is a grant where states can apply for so that we can investigate what are those pregnancy-related deaths and what can we do about them? What are those interventions that we can implement? And I'm going to pass it to Dr. Brittany Richards.
Thank you, Dr. Bryant. So we can't have a discussion about health disparities among Black women without talking about the health disparities that are around mental health. So when you think of mental health, it's the state of well-being in which you're able to realize your own abilities and you're able to cope with the normal stresses of life. So mental health is the foundation for individual well-being and the effective functioning of a community, which is why this is so important for us to talk about within the Black community, because for Black women, we need each other to be individually mentally healthy in order for the community to thrive. Although anyone can develop a mental health problem, African Americans sometimes experience more severe forms of mental health conditions because of unmet needs and other barriers. We see poverty, violence, racism, discrimination. These stressors ultimately play a role in how mental health is going to be affected. So when you think of this, 1 in 30 of people of color experience post-traumatic stress disorders. And this is from being able to see violence and within our community, they're having less access to care. So there's some barriers in mental health services, such as lack of information. People are not understanding what mental health is. The myth within the community that mental health is not something that is a Black disease. It's not something that we'll see. Anyone can develop a mental health problem, but because we saw that there were severe forms of mental health conditions with unmet needs, there's reluctance and inability to access mental health services, as well as this provider bias and inequality of care. When we looked at research, we saw that 63% of African Americans thought that depression was a sign of weakness. So we don't look at it as something that is well seen in our community, and we are seeing now that this is displayed within our community. When you think of Superwoman syndrome, this was a term coined in 1984, and it's basically saying that a woman will neglect herself because she's seeking to do it all, right? So as the Black woman, you hear this Black Superwoman myth. They're going out, they're having full-time jobs, they're wage earners, they're mothers, they're wives, and we're trying to balance everything on our plate. We're taking care of everyone else besides ourselves. So when we think of this, this is a coping mechanism that sometimes we see in the Black community, like I have to do everything, I have to be it all for everyone, but we don't stop and take a look at ourselves and say that we are what we need for our mental health, our mental well-being. So when you think of the strong Black woman, it's good that we're having celebrities such as Taraji P. Henson speak out and saying we do not have to be the strong Black woman. We do not have to be strong. We can be vulnerable. We need to express that we do sometimes feel weak and not feel affected by this. The strong Black woman was something that was first seen in slavery, when this had to be something that a Black woman was. You had to conceal your emotions. You had to be strong. So once it was a survival technique, now we're using it as a coping mechanism. And Black women aren't given the opportunity to be vulnerable. We're not able to show our feelings because on one side, we are looked at as aggressive or emotional, and we're judged differently compared to other individuals, other women. And then you look at social problems such as racism, discrimination, and sexism. So a Black woman is going to have to deal with her race as well as her gender. And this is connected to Black women being prone to mental health issues. So when our mental health is not being cared for, we're not suggesting, or we're not looking at providers to help us build up our mental health, then we start to see mental health disorders and mental illness. So approximately 30% of African American adults with mental illness receive treatment each year, compared to the US average of 43%, which we're seeing that's a 13% difference. Basically, when you're thinking of mental illness, it's affecting how a person's thinking, the feeling, their mood, and then ultimately they're not able to function within the community. And remember, we said that the community is going to thrive based on the individuals that are comprised of that community. So when you think of mental illness, again, genetics are going to play a role, but we see a lot of research geared to environment and lifestyle, which are going to heavily suggest if somebody is going to develop a mental health condition. Another statistic we saw was among adults with diagnosis-based need for mental health or substance abuse care, only 25% of African Americans received treatment compared to 37.6% of Caucasians. So again, we're seeing that there's about a 12.6 difference with people getting treatment and having the disorder. So in the African American community, especially Black women are going to look at mental illness as being stigmatized. We're often saying that it's a illness due to personal weakness. Again, that strong Black woman syndrome plays true. The perception poses a great risk in the community because people are not aware that mental illness is something that can happen within the Black community. So we need to really dispel a myth that mental illness in African American community does exist. And this concept of mental illness making one inferior is going to generally prevent an individual from seeking help even when they do have a mental illness. It's something that we'll say, well, I don't want my job to know. What if people would judge me? And African Americans are typically educated on prevention for commonly diagnosed physical illness, such as diabetes and hypertension. We spoke about these before, but we don't really talk about mental health. We don't talk about mental illness. And this is your emotions, your mental health. It plays a very big part in your physical well-being as well. So suicidal ideation among students in grades 9 to 12 is shown in this chart. And as we see that 22.4% of non-Hispanic Black girls. So remember, we were talking about Black women. Now we switch gears to Black girls. These are children who are 14 to 18 years old. And we see that there's a 1.1 ratio compared to non-Hispanic white girls. So these statistics are alarming for many reasons. But what stands out the most is that these young Black girls in grades 9 to 12 are contemplating suicide. And this is the future of the Black community. This is the future of motherhood in the Black community. And with all that we discussed, we know that most likely these young girls may not have the appropriate outlets to discuss their feelings. This is why we need to continue to be agents of change, and we need to advocate for the next generation, because these Black girls ultimately become Black women. It goes even further to discuss that 12.5% of these students who had suicidal ideation actually attempted suicide, as compared with 7.3% for non-Hispanic white girls. Again, you see that there's a ratio of 1.7. So this ultimately is something that we need to spend more time advocating for our patients. We need to spend more time communicating this to the parents and making sure that there's outlets that these children can be able to discuss their feelings. So when you talk about practice, we need to promote mental health literacy. We need to do mental health first aid trainings. We need to develop and implement services, programs, and make sure that our elected officials are having policy to ensure minorities are empowered through culturally informed, evidence-based practice. Again, we'll talk about the All of Us research program, where we need to make sure that medicine or mental health treatment is not one size fits all. It needs to be inclusive. We need to talk about advocating for our patients and making sure the language and culture around mental health disorders are inclusive and supported. More providers of color need to be involved, especially when it comes to mental health, in order to supply the high demand. We change the narrative by making sure that it's accessible. We promote awareness, accountability, and acceptance, and conducting studies, again, that are going to guide psychopharmacological treatments for patients from different ethno-cultural backgrounds. So again, how are we going to improve the conversation? First, we need to start the conversation. The first step in improving this conversation around mental health is to begin the conversation. We cannot continue to ignore it and act as if it's something that will disappear. We need to acknowledge the importance of mental health, and we need to be self-aware, again, of the language we use in regards to mental illness. Certain things like psycho, crazy, these are not appropriate terminologies to use. And we also need to actively listen. Listen for what the patient does not verbalize, and look for cues. So some resources that are out that we know about, for one, being in New York City, Thrive NYC, which was an initiative to help break down the barriers associated with mental health treatment and making sure that this is inclusive for people of all colors. NAMI Sharing Hope and Therapy for Black Girls, where it's an outlet where we can connect Black girls with Black therapists.
All right. So the last segment we're going to talk about, we talked about the risk factors, we talked about the reasons, we talked about some specific recommendations for decreasing the disparities and inequities. And now we're just going to kind of a little bit summarize what we discussed. And this kind of gives us the big picture of the health of African Americans. And again, we touched upon some of this, and how social determinants of health and health inequities, it ties into the morbidity, the incidence of heart disease, stroke. What are those risk factors, that poor nutrition, obesity, that lead to those disorders? which ultimately can lead to death due to cardiovascular disease, diabetes, liver. We know all this already. And what we need to do is really focus on those health services, those policies, access to health care, how it's being utilized in the workforce in order to prevent and treat these disorders. Other ways, we need to improve health equity by ensuring that everyone has access to high quality care, including high quality screenings, genetic testing, treatment, and also that people of color are getting into clinical trials so we can find the best treatments that fit for us. Because we know there are differences when it comes to our genetic background and why we're more prone to certain disorders. So we need to get to figure out why and then what are the best treatments for us, for Black women and Black people in general. We need to reduce the barriers to quality care. And we talked about this. This healthcare system in the United States can be complicated. So we need assistance. People need assistance with everything from getting the word out that we have these programs, to outreach, to education. How do we reduce risk factors? And when people are diagnosed with different disorders, the detection, diagnosis, and treatment. And we need to empower individuals and communities. We need to have more advocacy, getting people out there to fight for these programs, to make sure that politicians know how important it is, that we need to know elections are coming up. It's not just about the president, but we need to make sure we have people in power who are going to help us with these policies in Congress to help support fighting these health inequities, and including the insurers, researchers, and community leaders. And then, as my colleagues touched on, more research. Again, we need to understand how cultural, behavioral, and health system factors contribute to this unequal access. And we also need to work on customized care, as Dr. Barnes had mentioned. We need to also have research that's research-informed, evidence-based, that reduce healthcare disparities, that are feasible, and the key word is sustainable. We don't want to have these one-and-done programs that you get funded for a year and then they're over and done with. How do we sustain this work? And then lastly, as we touched upon, is again, understanding why these health issues disproportionately affect people of color, doing more research on that. And getting back to the fundamentals, we want to make sure that individuals are not using urgent care or the emergency department as their primary care place for receiving treatment. People need to have primary care providers. So that means we know that this improves population health. It gets people to have preventative services, prevents chronic diseases. People can be monitored over time instead of waiting for a crisis and going to the ED or the urgent care facility. But we know that there are obstacles for people to have primary care providers, such as language barriers and transportation we talked about. There's a limit of primary care providers. Not a lot of people are going into primary care. We need to have more nurse practitioners, more doctors getting into primary care and having hours that fit a population. People work 9 to 5. They cannot always take off work and afford that loss of income to fit within those hours. So having extended hours, having weekends, having evening hours. And we also need to understand the barriers. We need to offer support to our healthcare providers, maybe increasing the reimbursement so that more people will go into primary care, and develop interventions that expand primary care access. And lastly, patients want to be taken care of by others that look like us. So we need to increase the recruitment of diverse healthcare providers, and also increase the training of all healthcare providers on how to provide equitable care. We need to eliminate barriers for people of color getting into the health professions, whether that's financial barriers. We need community outreach. We need to start with our youth when they're young to expose them to the different healthcare fields, such as nursing and medicine and OT and PT. A lot of times they're not aware that these professions exist. And lastly, we need to promote Black women to leadership within these health institutions so that they can make the changes that are necessary. All right, and so that is all we have. So we're open to questions now.
Great. Thank you so much to all of you today. We do have a few questions that have come in. And one of the questions refers to the slide that you had that compared equity versus equality. Mm-hmm. And the question was about basically, I guess, identifying equity and equality and then looking at actually being in the stadium. So I think that's something some people may actually see when they look at that slide. I don't know if you want to bring it up again. Whereas although the people, they were on the boxes and you could see that they were put on a more level visual field. Now it's, they're still outside the stadium. So I understand the perception of the equity versus equality, but maybe you can address that a little bit about the whole idea about actually being in the stadium.
That's a good point.
Yeah, that's a good point. I guess I was looking at it from being able to see. That's kind of the perspective that I took it as. That again, even if you give everybody the same benefits, it doesn't mean that that person's still going to be able to achieve that goal. Which for me, I look at this as the goal of being able to see the baseball game. So sometimes you need to give people a little bit more so that they can get to that goal than somebody else may need. I don't know if anybody else had a different way they saw it.
No, that's exactly how I interpret it. That's how I interpret
Yeah.
it.
So the goal wasn't to be in the stadium, the goal was being able to see the game.
Visual. Okay, that makes sense.
But it's a worthy goal worth achieving, right?
Yes.
That really
Exactly.
to have the social justice that we talk about, there would not be
There would
any
no
wall
fence.
and no need for any of this.
Yeah.
Mhm. Right.
Exactly. I forgot. We want to be able to have the fence go on.
Right.
But until that
Exactly.
time.
That's definitely a good point to bring up and to think about when we look at the disparities and then also the access and all the things that contribute to the disparities in the African American women. And then another question came up regarding a discussion about the implicit bias that contributes to health disparities in maternal care, specifically with hospitalization. And so one of the resources I saw you mention, the American College of Obstetricians and Gynecologists. Are there any other major resources you may be able to recommend or share? We do have additional resources from your references that will be provided to everyone. But are there any others that you can think of that may focus specifically on the hospitalization and maternal care and the implicit bias that we discussed?
Yeah, it was a great one. I'm just gonna go to my reference list.
Sure.
I don't know about, was it hospitalization just particularly for maternity or?
Well, that was the question, specifically regarding maternal care, since you discussed. I think so. Can you still see the screen?
Okay.
Yes.
So here were some of the references that I used, particularly for the maternal slides. And I would say that this first one was excellent. It gave a great overview. This is a group of politicians. Some of them actually worked for Obama. There's an organization that put this together on what their recommendations were to fight the health inequities and inequalities, particularly around maternal health. So I found that first one was would be a great resource if somebody wants some more information.
Okay, thank you. And then we just have a few more questions. One is in regards to yourselves as Black women, DNP prepared. How do you approach your colleagues who you know may not actually be providing the culturally competent care that may be needed? Take a minute. I think one of the things that you mentioned that is very important is looking at those barriers, the access, the transportation. I know it's different for everybody. And although these are general things that we know tend to happen, tend to come up, it's somebody, they may not have an issue with transportation. They may be able to drive, whereas the next person, you know, they may not have a car. So I think one of those things that is important to consider is just the individual assessment of the patient.
Also, I think it's important to take advantage of your staff huddles and team meetings to discuss case studies, you know, like patients that are experiencing barriers, and collaborate with your mental health team. So it's not just you, the provider, trying to solve their solutions. You're working with your team to identify what are the barriers. So for example, when I discuss the patient that I referred to cardiology that has to wait 2 months for the appointment, a binder was created for a specific hospital that accepts patients without insurance. And so that's the go-to binder that we have. And the good thing is that they will see the patient. So regardless of the insurance status, whereas other hospitals will not accept them to be seen. So at least they have a starting point. And also the hospital, that a referral is really good at returning consultation reports. So that coordination of care piece is there. So working with a team, or if there are any psychosocial issues, you can look into your resources from your institution. My hospital has a home health program where they started to do home visits for patients who are dealing with 2 or more comorbidities and trying to improve their access to care. So they'll have even RNs come into the home and do asthma care. So if you have somebody who has persistent asthma, who's in and out of the hospital, and maybe had an ICU visit, for example, then they will be qualified for those programs. But you have to seek out the information. And so speaking with your colleagues, and also you learn as you go along, and you educate your colleagues about how to bridge the gaps in care.
I just want to add on too, I think educating your colleagues is very important, because obviously I'm a woman of color. Sometimes when you're working with your counterparts who are not a person of color, they don't understand. So for example, I have they'll complain, I have a patient that's always late, or this patient never gets their medication. Getting them to pause and say, have you ever asked the patient why? Why are they having a hard time? You might not know that they don't have a job, they don't have transportation, they got 3 kids they have to take to school, or maybe they're not getting that medication because they can't afford it because they decided to pay for food versus the medication. So I think not jumping to judgment, to look at the barriers and to dig a little bit further to see what the true cause is, instead of just, I hate this word, patient's not compliant. No, when patient's not following, that's something you need to discuss. You play a role in that to see why are they maybe not following that regimen. If there are barriers, and you need to identify those barriers and find ways to eliminate that barriers instead of just saying the patient's not compliant.
In some ways, I think one of the benefits of being in an educational environment is being able to use the sim lab, being able to use those scenarios so that the early career nurses can really learn facilitating what I call cultural humility, and understanding what are the issues that people, as you stated, face on a day-to-day basis, and just getting to your appointment is the success.
And also as an educator too, another area we need to work on is, we always teach, well, Black people are more prone to diabetes, they're more prone to this, but do we know why they're more prone to this? Instead of just throwing those kind of facts out, taking a deeper, look at the health disparities, why are they facing that at a deeper level versus just saying, if you look at a Black person, oh, they're probably going to have diabetes, they're probably going to have high blood pressure. That's one thing in education, as we educate our future healthcare providers, that we need to make sure that we're giving the full message.
That's good. And then we also have one more question, and this is also around that whole issue of access. Just this may be our last question. In rural communities, how can you suggest maybe working to reduce those barriers and the disparities, where in rural communities the resources might be more limited?
Telehealth.
Telehealth, telemedicine, and as Dr. Bryant mentioned, increasing funding. So meeting with legislators, talking about the pressing issues, getting it on their agenda, and emphasizing that funding needs to be in place to help address issues in rural community settings would help address these barriers. In addition to that, there are programs that are geared towards improving, and reducing the shortage of providers in remote areas. So providers can look to get, loan repayment as an incentive, but they are geared to bridging these gaps. So that's rural areas, underserved areas in urban settings, and also Native American reservations.
Thank you so much. Thank you all for this very informative presentation. There was so much great information shared. We hope all of you that have joined us today found this to be very valuable. You will see, as I mentioned in the beginning, that we are offering continuing nursing education credits. So that information is now available on your screen. We're grateful to the Columbia University School of Nursing for partnering with us to actually provide these credits available to you. And so please join us again. Again, you can visit us at www.jonasphilanthropies.org. If you would like to see more of our media library and our webinars and upcoming events. Thank you again for joining us. Have a great day.
Thank you for having us.
Thank you.